my argument, and I'll take you through it, is that our service scaffolding is actually weakest where it needs to be strongest. And I'll, perhaps in my next slide, try and explain why I think that has occurred. In terms of our origins in child and adolescent and adult mental health services, which it's come from medicine. And it's come from our treatment of many disorders, not mental health disorders. And if you see, for many other physical health conditions, that actually the big peaks, it starts sort of in early age and also late age, and isn't particularly such an issue around youth. But you look at mental health and you look at the peak and the bulk of mental health problems, actually they're occurring right in the middle of those two age points. And I think we've had services that have been developed and configured around a physical health medical model, and they're not appropriate for mental health, where most of our mental health service, the bulk of it, actually occurs in that middle age range between 10 and 30. Young people are trying to access services, and often they find that they're not youth-friendly. That thresholds, and I sit in adult services, the thresholds are set much too high so that they're not accessible to young people. And indeed in this store, as in many other stores, little to offer young people. They're not services that are configured to that age group. And I job share with a colleague, David Shires, whose daughter developed for psychosis at age 15. He said, at 15, sitting in a clinic where there were lots of toys and childish books, and I'm not in any way mischaracterising or characterising CAMHS in that bit, sort of saying it wasn't targeted. Equally, I know sitting in adult services that they're not configured to young people. They're configured to an age group who are much older and have had much, much longer problems. My husband is a GP. He sits in general practice in primary care, and what he says is, I know a young person's got a problem because they rarely come to see me. So when they do, I know they've got a problem. The system that young people experience is a very complex one, with lots of tricky pathways and interconnections or lack of connections. And young people have to somehow navigate through that pathway in terms of either bringing services together or finding themselves following very circuitous paths to the right kind of support. And ideally, what we want is some kind of very synchronous system where the bulk of problems are treated in primary care. Those who require specialist support are able to access it, but there's very good links and good pathways back into primary care. And that if they need tertiary support, that's there backing up and supporting secondary care, but again for a much smaller group, and there's that connectedness between tertiary care and secondary care and those pathways back into primary care. And that's the kind of system that we need to be working towards. And there are often few opportunities for child and adolescent services and adult mental health services to work together in a flexible and user-led way. They're often commissioned separately, they often sit in separate provider arms, they're often financed totally separately, and they're seen as competitors or working in parallel rather than actually working together, and that's a commissioning issue. And there's often very limited training opportunities for child and adolescent services and adult services to actually work and train together. On the TRACK study, which was a partnership project which actually followed 6 services, and it was called Mind the Gap, and it just looked at the transition, and it looked at it from a user perspective, from a service perspective, from a policy perspective, and I've just taken a few of the key points for that almost 40% of the young people with ongoing mental health who need to reach the transition boundary are never referred to AMHS and fall between that gap between child and adolescent adult mental health services. For the vast majority of those young people that they spoke to who were referred, the actual transition was poorly planned, poorly executed and poorly experienced by those young people. There were mutual misperceptions among clinicians which contributed to some of those ideological, practical and structural barriers between child and adolescent services and adult mental health services. And even where transition policies existed, there was a policy and practice gap, which Leslie alluded to, that you can have things written down on paper, but actually what is the experience in practice for a young person and family, and finding that it doesn't actually reflect what is actually agreed on paper. Even among those who crossed the gap, less than 5% experienced an optimal transition, and the outcomes of those who fall through the gap is unknown, because we don't know what happened to them. They disappear from services, and that's a major cause for concern, particularly when I've said to you that most of the major mental health problems are emerging, and some of these are lifelong, persistent mental health problems. They're not going to go away. So where do these young people go? Amateur status. A perception that the partner service was viewed as amateur or incompetent. And I left that in because I actually felt to some extent there can be some sense that adult mental health services know nothing about children or young people. Or it could be that equally child and adolescent services know nothing about serious mental health difficulties or diagnosis. You know, I've heard those kind of comments, and I do think there is to some extent that same perception that the other organisation is perhaps seen as less competent or amateur in respect of their contribution to this area. My husband describes mental health services, or he did, as a vacuum cleaner. He said that they suck people up and they keep them in there and you never see them again. And again, there can be a perception that adult services suck people into mental health and they never discharge them. The only discharge is when they die or someone leaves. So there can be a sense that maybe there isn't a sense that there should be some move on or some dynamic system where people return to ordinary lives and ordinary communities, and some reticence about that in terms of engaging people in a service which is seen as a vacuum cleaner and holds on to people. I wanted to tell you about a partnership in Worcestershire because we opened in 2002, but before 2002, from 2001, we met with our 3 CAMHS teams and started to look at how we might work together to deliver care to the 14 to 18 age group. And we set up a forum, and what we did was we actually took anonymised cases, real cases, and we looked initially with those anonymised cases at, from a service system, what they had experienced and what the relationship in working together, how that would be enhanced, what would we need to be different, or how, you know, what would be the contribution from adult services, what would be the contribution from CAMHS. And that led to a long discussion about how we work and realistic expectations of roles. And we agreed to support on a case-by-case basis. We developed agreements on how we shared and accessed case note records, and we developed a transition protocol. And then for the first 4 years, we met every 6 months to review actual cases that had gone through based on those agreements. And we looked at where it had worked well and celebrated that, but we also looked at problems that arose. Problems that arose that we hadn't anticipated in the original protocol, problems that arose in terms of access to case notes, problems that arose where maybe one service had an expectation on the other that they would be delivering something which was naive or a misunderstanding. And through that, and there were some tricky meetings. There were some, I can't say that it was an easy meeting. I've got some CAMHS colleagues sitting here that sometimes, you know, that they were heated meetings. And I remember one particular heated meeting which I wasn't at, but I heard about. And I came back and I said, I wonder what a family who got a 15, 16-year-old would have made of that last meeting when they heard 2 services that they are relying on to work together, what they would have made of that week meeting, what they would have made of it, when 2 services cannot be civil with one another, cannot speak together, cannot work together. What hope or optimism would I have as a young person or family that these 2 services were going to deliver the kind of care I needed across that span? And that's what we've got to remember, that actually we're not here for our service sake. We're here to deliver to young people and families, and we need to have them present in the room preferably, but present in terms of remembering this is what we're coordinating around, and we need to wrap services around them rather than create services which they fit into.